Movement of our body is controlled by a network of structures deep inside the brain, known as the basal ganglia. Ganglia means a group of cell bodies in the peripheral nervous system. Though traditionally called the basal ganglia, it is located inside the central nervous system. So, the term basal nuclei would be more accurate. You can think of basal ganglia as the brain's control center for movement. It allows us to start, stop, and adjust our actions smoothly. Imagine you want to bend your elbow. To make this happen, the biceps muscle needs to contract. At the same time, the triceps muscle needs to do the opposite, the relaxation. We cannot contract both biceps and triceps simultaneously. When one muscle contracts, the other antagonist muscle must relax. The basal ganglia help to organize these actions. Then, you can bend your elbow smoothly. The basal ganglia operate through two main pathways: the direct pathway and the indirect pathway. The direct and indirect pathways help the brain decide which movements to allow and which to hold back. This keeps our actions balanced and controlled. The direct pathway is like the brain's green light for movement. We can call it the let it go pathway. Here's how it works. First, a signal starts in the cerebral cortex. The signal heads to a part of the basal ganglia called the striatum. The cerebral cortex stimulates the striatum by sending an excitatory message. This message is carried by neurons in the corticostriatal pathway. These neurons can secrete a type of neurotransmitter called glutamate. When glutamate binds the receptors, it activates the other neurons. When the neurons in the striatum are activated, they send inhibitory signals to another part of the basal ganglia. This part is called globus pallidus. The neurons in the striatopallidal pathway secrete an inhibitory neurotransmitter called GABA. GABA means gamma-aminobutyric acid. Whenever neurons secrete GABA, they inhibit the other neurons. These neurons are called GABAergic neurons. Whenever neurons secrete glutamate, they activate the other neurons, and they are called glutamatergic neurons. The globus pallidus is divided into two parts: the internal and external segments. In the direct pathway, the inhibitory signals from the striatum are sent to the internal segment, GPI. Normally, GPI keeps the thalamus in check by sending it constant inhibitory messages to stop movement by secreting GABA. Here's the key. When the striatum inhibits the GPI's control over the thalamus is reduced. So, the thalamus is now freed. The thalamus can relay signals to the motor cortex. The neurons originating from thalamus to the motor cortex are glutamatergic, and thus they activate the motor cortex. The motor cortex then sends signals to your muscles through the corticospinal tract, and movement happens. In other words, the direct pathway works by disinhibiting the thalamus and letting you move smoothly. The indirect pathway works like a brake for movement. This pathway prevents unwanted or unnecessary actions. Here's how it works. It starts with the cerebral cortex, which sends signals to the striatum through the corticostriatal pathway. The neurons in the corticostriatal pathway are glutamatergic, and they excite the striatum. When the striatum is activated, it sends an inhibitory signal to another segment of the globus pallidus. Unlike the direct pathway, the signals are sent to the external segment of globus pallidus, GPE. The neurons from striatum to GPE are GABAergic. They are inhibitory. Here's where it gets interesting. The GPE doesn't connect directly to the thalamus. Instead, the GPE sends inhibitory signals to the subthalamic nucleus through GABAergic neurons. When the GPE is inhibited by the striatum, its control over the subthalamic nucleus is reduced. This allows the subthalamic nucleus to become more active. The subthalamic nucleus then sends excitatory signals back to GPI through glutamatergic neurons. So, GPI indirectly receives signals from the striatum through the subthalamic nucleus in the indirect pathway. When the GPI is excited, it increases its inhibitory control over the thalamus. This stronger inhibition on the thalamus decreases the activity of the motor cortex, making it harder for movement signals to get through. So, in simple terms, the indirect pathway applies the brakes on movement, making sure only the movements we need and want get through. It's like pressing down on the brake pedal in a car to keep things under control. The substantia nigra is another part of the basal ganglia. Substantia nigra plays a key role in organizing the direct and indirect pathways, which together help control our movements. The substantia nigra, pars compacta, has neurons that produce dopamine from their axon terminals. These neurons are called dopaminergic, and they project towards the striatum through a path called the nigrostriatal pathway. Dopamine has opposite effects on the direct and indirect pathways to achieve purposeful movement. In the direct pathway, dopamine binds to D1 receptors on postsynaptic neurons in the striatum. Binding on D1 receptors produces an excitatory effect. This makes striatum easier to inhibit GPI. When the GPI is inhibited, the thalamus is disinhibited. This means the thalamus is free to relay excitatory signals to the motor cortex. This extra signaling promotes movement. So, dopamine binding to D1 receptors enhances the activity of the direct pathway and thus facilitates motor movement. The effect of dopamine is opposite on the indirect pathway. Here, dopamine binds to D2 receptors on the postsynaptic neurons. Unlike D1 receptors, binding to D2 receptors has an inhibitory effect. This means there's less inhibition on GPE. GABAergic neurons from the GPE can send more inhibitory signals to the subthalamic nucleus. When the STN is less active, it sends fewer excitatory signals to the GPI. Now, GPI has less inhibition effect on the thalamus. So, thalamus can relay more excitatory signals to the motor cortex. So, binding D2 receptors reduces the activity of the indirect pathway. It is like releasing the brake and thus promotes movement. So, the dopaminergic neurons enhance movement by stimulating the direct pathway through D1 receptors and inhibiting the indirect pathway through D2 receptors. Now, we need to talk about another type of neuron in the basal ganglia. The striatum also contains interneurons that produce acetylcholine. The neurons are cholinergic. Acetylcholine has effects opposite to dopamine. In the direct pathway, acetylcholine has an inhibitory effect, and it reduces movement. In the indirect pathway, acetylcholine activates postsynaptic neurons, and the overall effect is decreasing movement. The balance of dopamine and acetylcholine in the basal ganglia is important for normal purposeful movement, and an imbalance can lead to pathological conditions. Parkinson's disease is a neurodegenerative disorder. In Parkinson's disease, the gradual loss of dopaminergic neurons in the substantia nigra. Over time, there is less and less dopamine in the basal ganglia. This causes the imbalance between dopaminergic and cholinergic action. This condition can lead to a range of movement-related symptoms. The motor symptoms can be remembered by the mnemonic trap. T for tremor, usually a shaking in the hands or fingers, often noticeable at rest. R for rigidity, stiffness in the muscles that can make movement feel restricted. A for akinesia or bradykinesia, difficulty starting movements or moving slowly. P for postural instability, trouble with balance, which can increase the risk of falls. The exact cause of Parkinson's is still unknown, but it's likely a mix of genetic and environmental factors. Age is the biggest risk factor. As people get older, the chance of dopaminergic neurons dying naturally increases. The average age for Parkinson's symptoms to begin is around 60 years, but it can occur earlier. In addition, if someone has a close family member with Parkinson's disease, the risk is slightly higher. However, having a genetic connection doesn't mean a person will definitely develop Parkinson's disease. And men are slightly more likely than women to develop Parkinson's disease. Typical antipsychotics, also known as neuroleptics, can block the action of dopamine in the striatum. These drugs are a common cause of drug-induced Parkinsonism. However, atypical antipsychotics can also cause drug-induced Parkinsonism, and the risk depends on the potency and dose of each drug. Certain chemicals, especially used in pesticides and herbicides, are known to damage dopaminergic neurons. Long-term exposure to these chemicals can increase the risk of Parkinson's disease. There's an interesting link between Parkinson's disease and certain illegal drugs. Some of the illegal drugs have been found to be contaminated with a chemical called MPTP, which is 1-methylphenol 1,2,3,6-tetrahydropyridine. MPTP is lipid-soluble. It can easily cross the blood-brain barrier. Once inside the brain, MPTP is oxidized into a toxic compound called MPP+. This metabolite is highly neurotoxic. It targets and destroys dopaminergic neurons inside the brain. When these neurons are destroyed, the person will have motor symptoms like slow movement, tremors, and rigidity. So, illegal drugs contaminated with MPTP can actually trigger symptoms that look very much like Parkinson's disease. While age, genetics, and some environmental exposures can increase the risk, the cause is complex and varies from person to person. So, what happens when dopaminergic neurons die in Parkinson's disease? Normally, dopamine is secreted by presynaptic dopaminergic neurons into the synaptic cleft. Dopamine binds D1 receptors on the postsynaptic neurons and stimulates the direct pathway. When the direct pathway is active, it encourages movement by sending let-it-go signals to the muscles. Dopamine also interacts with the indirect pathway. But here, dopamine binds D2 receptors on postsynaptic neurons and inhibits the indirect pathway. This blocks the indirect pathway's inhibition and also helps the body's movements smooth and easy. In Parkinson's disease, with fewer dopaminergic neurons, there's much less dopamine in the striatum. With less dopamine, the direct pathway isn't activated as easily. This makes the motor cortex difficult to initiate movement. With less dopamine, the indirect pathway is more active than it should be. The effect of the indirect pathway is to limit movement. The overall effect of dopamine shortage weakens both the let-it-go effect of the direct pathway and the brake-release effect of the indirect pathway. So, patients find it challenging to initiate purposeful movement. These changes explain the hallmark of motor symptoms in Parkinson's disease. For instance, starting to walk takes a lot of effort. The loss of dopaminergic action makes the patient difficult to start movement, and their steps are shorter and slower. Slower, smaller movement is called bradykinesia. The patient takes shorter steps and slides their feet along the ground instead of lifting them off the floor. This is known as shuffling gait. Stopping also takes some effort, since muscle contraction is slower to kick in, so it is difficult to stop movement suddenly. Patients typically hardly swing their arms while walking, because these movements become too slow to notice. So, the arm swing is not obvious. Staying balanced also requires fast muscle responses. So staying in a stable posture during turnaround or resisting from a push becomes harder. This postural instability can lead to frequent falls. Facial expressions like smiling or frowning use many muscles of facial expression. Since these muscles are harder to work, patients will have fewer natural expressions over time. This results in what's known as a mask-like face. The patient's face appears expressionless. In severe cases, as more and more dopaminergic neurons are damaged and dopamine levels drop very low, movement can nearly freeze. It is extremely difficult for patients to initiate any action. They don't move at all, and this is known as akinesia. So, bradykinesia, akinesia, and postural instability are mainly due to low levels of dopamine. When dopamine levels drop, the influence of acetylcholine becomes stronger. So think of acetylcholine as a kind of brake that helps balance the effects of dopamine in the basal ganglia. When there's too much acetylcholine compared to dopamine, it strengthens the indirect pathway. This pathway resists movement, and with more acetylcholine activity here, muscles can't move as freely. They become stiffer. High level of acetylcholine makes the muscles constantly resist even passive movement throughout the entire range of motion. This is called lead pipe rigidity. This type of resistance is often more noticeable in the lower limbs. Sometimes, though, acetylcholine acts as more of an on and off brake on passive movement. This produces sudden, brief stops followed by quick releases during passive movement, and this is called cogwheel rigidity. Cogwheel rigidity is most noticeable in the upper limbs. Acetylcholine can also trigger repetitive, rhythmic activity in certain neural circuits, which is believed to be linked to resting tremor. This tremor isn't directly caused by muscle contraction. Instead, it results from oscillating signals in cholinergic interneurons. The classic tremor in Parkinson's disease is the pill-rolling tremor at rest. It has a frequency of about 4 to 6 Hz and tends to start on one side of the body. Interestingly, this tremor often disappears when the person tries to move voluntarily. Let's look at what dopamine does in the synapses and how it's metabolized. We start with tyrosine, an amino acid we get from food. Tyrosine can cross the blood-brain barrier and can be taken by dopaminergic neurons. Inside these neurons, an enzyme called tyrosine hydroxylase converts tyrosine into levodopa. Another enzyme, dopa decarboxylase, converts levodopa to dopamine. This dopamine is stored in small packets, or vesicles, within the presynaptic axon terminals, and they are ready to be used. When an action potential arrives at the neuron, dopamine is released into the synaptic gap, which is the small space between neurons. The next neuron in line, known as the postsynaptic neuron, has receptors to receive dopamine. The neurons in the direct pathway have D1 receptors. When dopamine binds to D1 receptors, it activates the direct pathway and enhances movement. The neurons in the indirect pathway have D2 receptors. When dopamine binds to D2 receptors, it inhibits the indirect pathway. This reinforces movement by preventing unnecessary inhibition. So, dopamine helps increase motor activity through both pathways. After dopamine is released, it doesn't stay in the synapses indefinitely. Some dopamine is broken down by an enzyme called COMT, catechol-O-methyltransferase. This enzyme converts dopamine into an inactive substance called 3-MT. Some dopamine is reuptake by the original presynaptic neuron. This neuron has another enzyme called monoamine oxidase B. This enzyme is located on the outer mitochondrial membrane. MAO-B breaks down dopamine into another inactive substance called dopac. The remaining dopamine is stored in vesicles for later use. In Parkinson's disease, fewer dopaminergic neurons mean less dopamine in the brain, which causes problems with movement. To help restore dopamine levels and improve motor function, we can use different types of medication. One main drug is levodopa. Levodopa can cross the blood-brain barrier where it's taken up by dopaminergic neurons. Inside the neurons, an enzyme called dopa decarboxylase converts levodopa into dopamine, raising dopamine available in the brain to improve movement. However, there are dopa decarboxylase enzymes outside the brain, and they can convert levodopa to dopamine in other parts of the body before it reaches the brain. Dopamine can't cross back into the brain. This can lead to unwanted effects of dopamine in the body rather than in the brain. We don't want L-dopa to be converted to dopamine outside the brain. So we want to block peripheral dopa decarboxylase. Carbidopa is a drug that blocks the dopa decarboxylase enzyme outside the brain. When we give levodopa-carbidopa combination, less L-dopa is converted to dopamine in peripheral tissues. More L-dopa can reach the brain, and more dopamine can be produced in the striatum. Another way to improve dopamine signaling is to give drugs that can produce similar action of dopamine. These drugs are called dopamine receptor agonists. Dopamine agonists can bind directly to dopamine receptors in the brain and produce the similar effect to that of dopamine. They can boost motor activity even with lower dopamine levels. To maintain more dopamine in the brain, we can also use drugs that slow down its breakdown. MAO-B inhibitors, such as selegiline and rasagiline, block the enzyme monoamine oxidase B. When less dopamine is metabolized, more dopamine can be recycled. COMT is another enzyme that breaks down dopamine. COMT can be found in peripheral tissues outside the brain. This peripheral enzyme can also break down L-dopa into a byproduct called 3-OMT before it even reaches the brain. So less L-dopa enters the brain and is converted to dopamine. This decreases the effect of L-dopa. To counter this, we can use COMT inhibitors like entacapone and tolcapone. These drugs block COMT peripherally and allow more L-dopa to reach the brain. Tolcapone can even cross into the brain. It can block COMT in the synapses, helping to preserve more dopamine. Amantadine is another drug sometimes used to control motor symptoms, although its exact action isn't fully understood. It seems to help by influencing dopamine synthesis, release, or uptake in the brain. In Parkinson's disease, acetylcholine levels can be relatively high, and patients may have motor symptoms like tremors and rigidity. By using anticholinergic drugs such as trihexyphenidyl, benztropine, or procyclidine, we can reduce the effects of acetylcholine. This helps to control tremor and rigidity, though it has little improvement on bradykinesia. The aim of these treatments in Parkinson's disease is to restore the balance of dopamine in the brain, making movement smoother and easier. However, it's important to note that while these drugs can improve symptoms, they don't stop the loss of dopamine-producing neurons over time. As Parkinson's disease progresses, a combination of different medications may be needed to help relieve motor symptoms and improve quality of life. Now, let's talk about the pharmacology of each drug. The first one is levodopa, also known as L-dopa. L-dopa is often the first-choice medication for treating Parkinson's disease because it effectively replenishes dopamine in the brain. Here's how it works. L-dopa is an intermediate form of dopamine, and when taken orally, it is absorbed in the small intestine and then enters the bloodstream. Importantly, L-dopa can cross the blood-brain barrier. This means it reaches the brain where it's needed. Once in the brain, in the presynaptic terminals of dopaminergic neurons, L-dopa is converted into dopamine, helping to restore dopamine levels. By increasing dopamine, more dopamine can be released into the synapse. More dopamine can bind to the D1 and D2 receptors in the brain and produce smoother, more controlled movement. So L-dopa helps to improve motor symptoms like bradykinesia. Although L-dopa is well absorbed from the small intestine, it has a short half-life of about 1 to 2 hours. The drug doesn't stay long in the bloodstream. L-dopa is quickly converted into dopamine by the peripheral dopa decarboxylase enzyme even before it reaches the brain. This limits the effectiveness of treatment as dopamine cannot cross the blood-brain barrier. So L-dopa is usually combined with Carbidopa, which blocks the peripheral dopa decarboxylase and stops the metabolism of L-dopa outside the brain. Carbidopa doesn't cross the blood-brain barrier, so it only prevents L-dopa from converting to dopamine in the peripheral tissues. This combination allows more L-dopa to reach the brain, which makes it more effective at a lower dose and reduces unwanted side effects outside the brain. L-dopa is converted to dopamine in peripheral tissues. We don't want high levels of dopamine in peripheral tissues. High dopamine levels produce unwanted effects. In the gut, dopamine can bind to dopamine receptors and slow the intestinal movement. This can lead to symptoms like nausea, vomiting, and loss of appetite. In blood vessels, especially when dopamine binds to D1 receptors, blood vessels dilate. This can lead to postural or orthostatic hypotension. When someone stands up quickly, they may feel dizzy or lightheaded. By combining L-dopa with Carbidopa, we can reduce these peripheral side effects and get more of the beneficial effects of dopamine in the brain. However, when too much dopamine reaches the brain, it can lead to both motor and neuropsychiatric side effects. While dopamine is essential for motor control, it's also released when we experience something enjoyable or beneficial, making us feel good. This helps us link that enjoyable feeling with the activity, encouraging us to repeat it. However, with high dopamine levels from L-dopa therapy, patients can develop excessive reward-seeking behaviors, like compulsive gambling, hypersexuality, binge eating, or even obsessive shopping. These are known as impulse control disorders and are fairly common side effects of Parkinson's treatments that increase dopamine. Too much dopamine in specific areas of the brain might also contribute to psychosis. When dopamine levels are high, it can overstimulate the brain, leading people to find intense meaning in things that wouldn't normally have it. This phenomenon can lead to symptoms like hallucinations or delusions. Dopamine also has a minor role in regulating the sleep-wake cycle. Increased dopamine activity, particularly in the thalamus, can lead to excessive daytime sleepiness. This is another potential side effect for Parkinson's patients on dopaminergic medications. L-dopa is incredibly effective for managing the motor symptoms of Parkinson's disease, especially at the start of treatment. In the early stages, it's easy to adjust the medication to maintain dopamine levels within a therapeutic range, which helps control movements and improve symptoms. However, since L-dopa cannot stop the loss of dopaminergic neurons, managing symptoms becomes harder. To be effective, L-dopa is converted to dopamine in the axon terminal of the dopaminergic neurons. Less dopaminergic neurons means less L-dopa is converted to dopamine, and less dopamine is secreted into the synapse. Larger doses of L-dopa are needed to control symptoms as the disease progresses. Patients may notice that the effects of the drug don't last as long as they used to. Symptoms start to return before it's time for the next dose. It's like the medication's effects fade, so patients start feeling stiffness and slowness again as dopamine levels drop. This is called the wearing-off reaction. To manage this, we can often adjust the timing of doses or add another medication to help make the effects last longer. Another common effect is the on-off phenomenon, which involves sudden, unpredictable shifts in movement control. This is different from wearing off. The wearing-off reactions are predictable, but the on-off phenomenon is unpredictable. Patients can go from feeling like they're moving well or on state, and then to suddenly feeling stiff or frozen, as if their motor activities are switched off. This shift can happen quickly, making daily activities more difficult. One way to manage on-off phenomenon is to give smaller and more frequent doses of levodopa to try to smooth out the effects and reduce on-off phenomenon. L-dopa temporarily restores dopamine, but because the drug has to be taken several times per day, dopamine levels rise and fall. These fluctuating levels and the continued loss of dopaminergic neurons make it very hard to keep a steady level of dopamine. When dopamine levels are at their peak after a dose, it is hard for patients to stay still and can lead to involuntary movements. This condition is known as L-dopa-induced dyskinesia. These are jerky, uncontrolled movements. They are different from resting tremors. They're not painful, but can be disruptive. These motor side effects, such as wearing-off reaction, on-off phenomenon, and dyskinesia, are common with long-term use of L-dopa. Another group of medication that can be used to control motor symptoms is dopamine receptor agonists. These are older drugs like bromocriptine, which is an ergot derivative, but they're less commonly used now because of their side effects. Newer drugs are more commonly prescribed because they tend to have fewer side effects. These drugs include pramipexole, ropinirole, rotagotine, which is available as a skin patch, and apomorphine, which can be used for quick relief during sudden off episodes. Dopamine receptor agonists do not need to be converted into dopamine like L-dopa does. Instead, they can bind directly to dopamine receptors in the brain and activate them. By doing so, they can help compensate for the lack of dopamine and improve motor symptoms to some extent. There are different types of dopamine receptors in the brain, but D1 and D2 receptors are mainly involved in movement. Dopamine agonists target the D2 receptors, produce similar effects as dopamine. They inhibit the indirect motor pathway and promote movement. Dopamine receptor agonists are often used in the early stages of Parkinson's disease, especially in younger patients. Younger patients mean patients under 60 years. In some cases, they are used as monotherapy in younger patients with mild symptoms to delay the need for L-dopa, helping to postpone L-dopa-induced dyskinesia, which is commonly associated with long-term use of L-dopa. Dopamine agonists have a longer half-life than L-dopa. Dopamine agonists are also used as add-on therapy with L-dopa in more advanced stages to help smooth out motor fluctuations, such as the wearing off or on-off phenomena. When used together with L-dopa, they help reduce the dose of L-dopa needed. Since they don't rely on dopaminergic neurons, they can work even when the disease progresses and those neurons are lost. In advanced stages of Parkinson's disease, very few dopaminergic neurons are left, and the patient may experience sudden stop of movement. In such a situation like akinetic crisis, we can give subcutaneous apomorphine. Apomorphine is a very strong dopamine agonist. It can relieve akinetic crisis by stimulating dopamine receptors. Dopamine agonists have some potential side effects. They can activate dopamine receptors in the gut, decreasing intestinal movement. This can cause nausea, vomiting, and loss of appetite. They can also activate the dopamine receptors on the vessels and cause vasodilation. Blood pressure can drop when standing up suddenly, leading to dizziness and orthostatic hypotension. Dopamine agonists can cause drowsiness, yawning, somnolence, and daytime sleepiness. Some patients feel drowsy or even fall asleep suddenly, which can be dangerous during activities like driving. Because dopamine is involved in the brain's reward system, dopamine agonists can cause impulsive behaviors like compulsive gambling, binge eating, or hypersexuality. Excessive stimulation of dopamine receptors, particularly in the mesolimbic pathway, can lead to psychotic symptoms such as hallucinations and delusions. These neuropsychiatric side effects are more common with dopamine agonists than with levodopa. So, it is better to avoid dopamine agonists in older persons with a history or risk of psychosis or impulse control disorders. We need to be very careful when the drug is given to older persons with cognitive impairment and orthostatic hypotension. To minimize side effects, we can start a dopamine agonist with a low dose and gradually increase the dose. Now let's talk about MAO-B inhibitors. MAO-B is one of the enzymes that breaks down dopamine in the brain. Selegiline and rasagiline are commonly used to manage Parkinson's disease. These drugs selectively and irreversibly block monoamine oxidase B enzyme. So, less dopamine is metabolized. More dopamine is preserved and reused by dopaminergic neurons. Blocking the MAO-B enzyme increases the effect of dopamine already present in the brain. These drugs can moderately improve motor symptoms. Although they are less potent than L-dopa, MAO-B inhibitors are often prescribed early in the disease. The reason is that they have fewer motor side effects than levodopa. They also cause fewer neuropsychiatric side effects compared to dopamine agonists. When these drugs can be given together with L-dopa, MAO-B inhibitors can prolong the effect of L-dopa and smooth out motor fluctuations such as wearing off episodes. This combination is useful in later stages of Parkinson's disease. However, these drugs have some notable side effects and drug interactions. When selegiline is metabolized, amphetamine-like byproducts are produced. These byproducts are psychostimulants. They may cause insomnia and other stimulant-related side effects. Rasagiline doesn't produce amphetamine-like metabolites. So, it is a better choice for patients sensitive to side effects. MAO-B inhibitors can interact with selective serotonin reuptake inhibitors. Selective serotonin reuptake inhibitors are usually prescribed to treat depression in Parkinson's disease. Although selegiline and rasagiline selectively block MAO-B, at high doses, these drugs lose selectivity and start blocking MAO-A enzymes. MAO-A are directly responsible for breaking down another neurotransmitter called serotonin. Blocking MAO-A slows the breakdown of serotonin. SSRI increases serotonin by preventing its reuptake. Together, they can cause serotonin overload in the brain. Too much serotonin can overstimulate the nervous system. High level of serotonin can include mental status changes such as anxiety, restlessness, or psychosis. It can cause autonomic manifestations such as sweating, rapid heartbeat, high blood pressure, vomiting, diarrhea, or dry mouth, as well as neuromuscular hyperactivity such as tremors, muscle twitching, muscle rigidity, or loss of coordination. The risk of serotonin syndrome is lower with selective MAO-B inhibitors like rasagiline or selegiline compared to non-selective MAO inhibitors. When we don't want to degrade dopamine too quickly, we can use another enzyme inhibitor. COMT inhibitors block catechol-O methyltransferase, an enzyme that breaks down dopamine. They act in two main places. In peripheral tissues, COMT can even break down L-dopa before it can reach the brain. Drugs like entacapone or tolcapone are used to block this enzyme. When less L-dopa is broken down in peripheral tissues, more L-dopa can reach the brain. Tolcapone has an added effect. Tolcapone works both outside and inside the brain. It can cross the blood-brain barrier and block COMT inside the brain. Tolcapone prevents dopamine from being broken down in the synapses. This means dopamine can stay longer in the synapses, improving motor symptoms. Tolcapone is more potent but less commonly used due to the risk of serious liver damage. COMT inhibitors are not used alone in Parkinson's disease. They are often added to L-dopa therapy. The effect of L-dopa may wear off over time, causing motor fluctuations. COMT inhibitors help smooth out these fluctuations by prolonging the duration of action of L-dopa. When L-dopa-induced dyskinesia can't be controlled, we can use Amantadine as an alternate option. Amantadine was originally developed as an antiviral drug. It has benefits in Parkinson's disease. Although the exact mechanism is not known, it boosts dopamine level by increasing the release of dopamine stored in the presynaptic neurons. It prevents dopamine reuptake from the synapses. It makes the effect of dopamine last longer. The stridopalatal neurons have NMDA receptors that receive excitatory glutamate signals. Amantadine can block NMDA receptors. This effect also reduces L-dopa-induced dyskinesia. Let's talk about anticholinergics. In Parkinson's disease, there's an imbalance between two neurotransmitters. Dopamine levels drop because dopaminergic neurons are damaged. Acetylcholine becomes too active as it's no longer opposed by dopamine. When too much acetylcholine binds to muscarinic receptors, they cause symptoms like tremors and muscle rigidity. Anticholinergic drugs like trihexyphenidyl or benztropine block the muscarinic receptors in the brain. By doing this, they reduce the action of acetylcholine in the synapses. This reduces tremors and muscle rigidity. However, these drugs don't do much for bradykinesia or problems with balance. They're mostly used for managing resting tremors in younger patients. In older patients, there is increased risk of memory and cognitive problems. This is because acetylcholine is important for learning and memory. Blocking muscarinic receptors can cause confusion or memory problems, especially in older adults. Additionally, blocking the effect of acetylcholine can lead to other side effects. They relax the ciliary muscles in the eye, reduce saliva production, reduce bladder contraction, and slow down the movement of the gut. These can lead to blurred vision, dry mouth, urinary retention, and constipation.